Very good morning to everyone. Myself Dr. Divya Kumari, and I will be presenting my topic, restoring ocular integrity of perforated corneal ulcer using host tissues derived from keratoplasty. Aim of the study was to report initial clinical outcomes of therapeutic PK of perforated corneal ulcer using host corneal button. The therapeutic penetrating keratoplasty is a surgical procedure to restore globe integrity or to resolve infectious or inflammatory keratitis unresponsive to medical treatment. COVID-19 pandemic caused unprecedented crisis to corneal surgeons. There was acute imbalance of demand and supply of tissues. We report 2 cases that required therapeutic PK and were managed successfully by graft derived from host tissues of patients undergoing optical PK for PBK. Case 1, she was a 28-year-old female, history of trauma with wooden stick for 6 days duration. She had a complaint of redness, discharge and decreasing vision in right eye and was previously treated with eye ointment itraconazole, eye drop moxifloxacin, eye drop tobramycin and eye ointment atropine with no symptomatic relief. Systemically, she was within normal limit. On ocular examination, we could see visual acuity was hand movement close to face with PR accurate in all quadrants, and in cornea, we could see perforated corneal ulcer of greatest diameter of 5.1 into 4.2 mm with 0.5 mm diffuse stromal infiltrate in surrounding corneal stroma. Fundus examination was done with the help of B-scan ultrasonography, and it was found to be normal. Preoperative investigations were normal, and KOH wet mount showed filamentous septate fungi, and SDA showed Aspergillus species. Management was started, and patient was put on eye drop 5% natamycin 1 hourly and eye drop homatropine 2% 4 times a day and eye drop moxifloxacin 6 times a day, and tablet ketoconazole was started 200 mg twice BD. And further therapeutic PK with intracameral injection of voriconazole was performed using glycerine preserved non-vascularized host graft obtained from optical PK of PBK patient. Size of graft was 7.5 mm. On post-operative day 1, graft clarity was 0. Graft-host junction was well opposed, anterior chamber was formed, and patient was maintained on same medications as pre-operatively. Patient was followed up weekly for the next month. Graft clarity didn't improve, but there was no recurrence of infection. Follow-up through telemedicine services was done. At 1 year, graft was completely opaque with inferior conjunctivalization. Anterior segment OCT was done with top-con DRI OCT triton. Optical PK was performed after 1 year. The final visual acuity at 1 month post-operative visit was 636 parts with a phakic correction. Histopathological examination showed stratified squamous non-keratinized 5-layer epithelium. These are the pictures. In February 2022, this is a case 2, 68-year-old female presented with complaints of redness, pain, photophobia and decreased vision in left eye for duration of 1 month. Vision in left eye was PL positive with PR accurate, and we could see left eye had perforated corneal ulcer of size 4.7 into 4.5 mm with Descemet's membrane folds and shallow anterior chamber. Rest of the examination were within normal limit. KOH wet mount showed filamentous septate fungi, and SDA showed Aspergillus species. Systemic examination was within normal limit. Treatment was started same as the first case, and therapeutic PK with intracameral injection of voriconazole was done, and with non-vascularized host tissue obtained from optical PK of PBK patient. The graft size was same. Post-operative day 1, graft clarity was 1+, and graft host junction was well opposed. Anterior chamber was formed. No exudate or hypopion was noted. Follow-up was done weekly for 3 weeks. First 3 weeks, and no recurrence of infection was noted. Graft was well epithelialized at the end of 1 week due to widespread pandemic. He was followed up by telemedicine services. At 1 year, follow-up visual acuity in left eye was perception of light with projection of rays accurate in all quadrants. Graft clarity was 0 with devascularization as 4 and 5. These are the pictures. During lockdown, the number of donor corneas collected and thus emergency therapeutic PK performed decreased significantly. Tissues from other eye banks also could not be transported. People started using glycerol preserved corneas or scleral patch graft for therapeutic purpose. We anticipated tissue scarcity due to COVID-19 pandemic and promptly preserved 4 host tissues derived from optical PK and glycerol. Tissue were utilized on day 6 and day 8 of their storage respectively. Because even glycerol preserved corneas were not available, therapeutic take-home message is therapeutic PK using host tissue obtained from the recipients of optical PK are safe and effective option to restore ocular integrity in cases of emergency during shortage of fresh or glycerol preserved corneas. Optical PK is required for visual rehabilitation later. Thank you.
Thank you, Dr. Divya, and that's a good presentation.
Yeah, good presentation, Divya. Did you do the serological test for these host tissues?
Yes, ma'am. Actually, these host tissues were obtained from optical PK patients who were already before surgery. We do serological test in all those patients. So during
do you
optical,
do serological test for all your optical keratoplasty patients?
all patients, irrespective of any case, we do serological test.
Okay.
I have, it's a very good idea to use host tissue, uh, obviously during the COVID time, but I have two reservations with this. One is the PBK could be because of any reason, sometimes CMV or sometimes HSV can lead to corneal decompensation, and that can have a recurrence in the patient who's undergoing transplantation. That is one thing. The other thing is the size of the graft. Usually PBK we take 7.5, and for therapeutic usually the size which you showed was almost
Small
at the
size.
almost like was looking like 5, 6, 7. So you would want a large graft so that no recurrence, although there was no recurrence in any of the case. But always keep in mind, I think PBK etiology could be anything. It may not be just a corneal decompensation, age-related, or following a cataract surgery.
Okay, sir.
That could lead to recurrence of disease in the patient who's undergoing transplantation. Otherwise, it's a good idea.
Thank you.
Thank you. Good presentation.